So good morning, everyone. It gives me a great pleasure to be here because I actually did my PhD here. I actually lived in London, Ontario for 12 years, since 1990 till 2002. So I did my PhD, then I was working as a faculty here also at Western and the LHSC and so forth. So it has been 16 years, but every time I come here, it's a great pleasure. I have a lot of friends in the city. I'm always amazed, living in LA, coming here, how green and clean and nice it is here. It's a little rainy, but it's okay. So I will be talking today. This is like a teaching session about cardiac PET. So I know you have a PET-MR here and PET-CT from GE. I think I don't know what else you have here. Right now, you can tell me later, but this will be about the latest techniques in PET and cardiovascular PET, instrumentation and also like the reconstruction and things like that. Do you all read PET? Look at PET scans here? Yeah, so, okay. So these are my disclosures. We have Siemens grants. We have 2 NIH grants. One of them is related to PET reconstruction and motion correction. We also get royalties for the software we develop, including quantitative software for PET. So today, there will be like 3 topics here. And we have 1.5 hours, but I'll try to finish in about 1 hour. And then we can discuss. It's been a lot of different talks I have to give here, so I have to save my voice. First we will talk about the latest PET-CT, and then something which relates to PET-CT and PET-MR and everything. It's really central to quality, imaging quality in cardiovascular imaging is the motion of the patient, of heart, and so forth, and motion of the patient and how we can correct for that. And then we talk a little bit about PET-MR technologies. So starting with PET-CT, we have, there's several systems right now, as you're familiar, and there is a fierce competition between different vendors. Actually, this picture was taken a long time ago in London, Ontario. I'm just trying to get my mouse here. Oh yeah, here. That picture was taken in London, Ontario, when the brand new GE system at that time when I was leaving came to St. Joseph's, and we just ripped apart the covers, and we're taking the physicists like to go inside and check what's inside. So here is you see there's like a bank of the PM tubes and the ring and so forth. That's what it looks inside more or less. All the scanners look like that. And there's different types of scanners. This is your typical analog photomultiplier tube and the crystal. So your PET scanner the typical scanner is built with this kind of device, like this kind of elements. But I will talk about the digital PET also. So it's a little different because this is not a digital PET. This is like an analog PET. So I don't know if you're familiar with this. Probably you are. When we started, like long time ago, we were doing 2D PET. That means each slice was kind of separately focused. We had something called septa, lead septa, and we were mostly collecting counts within one slice or within a couple of slices. That was good and bad. The good thing was there was very little scatter, but the bad thing was that we got less sensitivity because we're losing all those possible photons. And in cardiac imaging, for the longest time, this was persisting. Like all the cardiac papers, when you read like the seminal papers in blood flow and everything, it's all done with this 2D. And this is quite different now. And for the longest time, people were saying that it really doesn't work for 3D, some of the like rubidium scans and so forth. But right now, the way it is, none of the new scanners have 2D mode even available. So you really have to do everything in 3D. However, if in the US at least, I don't know how it is in Canada, they have like a lot of old scanners, like a used market, and a lot of the old scanners, they will actually have this 2D mode, So it's very important to know which mode you are doing the scans because it's quite different. So here's a big table, and you'll have it in your recording. So we want to focus a little bit on this table. So we put together like the latest 2 PET CT scanners from each vendor, main vendor, Siemens, Philips, and GE. And we put like some major characteristics of them. So this is, and you see this is more or less the same, the port of the, how big of a patient you can put through. How many CT slices you have, and you see now the new systems now mostly go up to 128 slices, so that allows you a full-blown CT angiography for coronary. And actually the next session I will show you quite a bit about the coronary PET and coronary CT angiography with PET on those machines. So it's going to be something special in the next session. But for now, just remember that you have like a pretty much the state-of-the-art CT with those systems. Is not like, usually it's not like the best from the vendor. It's like a second best, but it's pretty good for major cardiac imaging. Here is the crystal size, and that's the size of those crystal elements. You can imagine that the smaller the crystals, the better resolution will be at the end. And really, you don't want to say which vendor is better. It's more related to the time of introduction. So that latest, the one here, highlighted in green, that scanner, it just has been released, I think this SNM. So this is the latest scanner from any of the vendors. And you can see that it has like the highest performance here, because it has the crystal size, for example, they were all about 4 millimeters here. This is going down to 3.2 millimeters now. So the smallest crystal size, so you can imagine the details will be, better. Now, this is something important here is the type of the photomultipliers. And you see that these systems, I don't know what you have here. I presume you have analogs. Most of the GE systems to date were analog. However, there is the new scanner from GE, for example, here, Discover MI, is already not analog, is the silicon photomultiplier. SIPM is silicon photomultiplier. So this is something where instead of the photomultipliers like you put like a silicon, which means it's just like a semiconductor material, and that actually will be used as a photomultiplier. Here is the Philips, and you can see the Philips has one analog system, recent one, but then there's Vereos, which is actually something a little different, which is actually fully digital silicon photomultiplier. It's quite different than other scanners. Does not necessarily mean there's a better scanner, but it's a different technology. And here on the Siemens side, we use Siemens a lot. We have the MCTs. Most of our the scans I work with are done on this scanner. It was analog, but now the new scanner is actually digital. So there's quite a bit of change just happening right now, that you start switching from this analog photomultiplier to this digital system. So material here you see is BGO, LSO, so those are different crystals, and sometimes the vendors don't want to even say what it is exactly, but it's some kind of lutetium orthosilicate based crystal. But so most of them are LSO based. And here is a very important parameter. This sometimes this is given in a different units, like counts per second per becquerel and so forth. Sometimes it's a little confusing for the clinician. So actually you can convert this into relative sensitivity. That's easier to understand. So that is a key parameter when you buy or use a PET-CT scanner. That tells you, like that parameter here, the way I present it in percent, sometimes they show it like this, is if you put a patient, what percent of the counts you actually record in the scanner. So easy to understand. So because you lose a lot of counts, you can imagine. So assuming you get a perfect no attenuation and so forth, what will be your sensitivity, like a relative sensitivity of how many counts coming out of the patient would end up being recorded. And it's some people are quite amazed that it's still only like 2% or so. So for SPECT, actually it's like 100 times lower than this. So if we do SPECT scans, it's actually 100 times lower. But this is, so the best in the field is about 2%. You see that the typical scanners which you have so far, I think they're about, you know, and these are the very latest scanners. Typically it's like around 0.7 or so %. But the latest scanners are, you know, about here is like 1.6, 2%. So what that means is, for example, that you could put a patient with half the dose and you get the same number of counts as you would have in the old system. Or, you know, you could get twice as good images, higher quality images with the same dose. So this is a very important parameter. This is the resolution, and you see that that resolution goes to like 4 millimeters, and on those latest systems goes down to like 3.2 millimeter even. But that resolution is further, you can further push it by using special reconstruction we will talk about to something like 2 millimeter effective. Even though like the actual physical resolution is 4 to 3 millimeter, you actually can push it up by using special reconstruction tricks. And then now the other very important parameter here, and this is the net equivalent count rate in kilocounts per second. And what that tells you is at what point, so it tells you like how many counts that scanner can take before it starts saturating. So all the PET scanners saturate at some point. If you give it too much activity, it stops. At some point, if you give it like certain amount of activity and double it, it will still show the same or less because it's just saturated. It cannot cope with it. And that's usually was not a problem for the 2D scanners. It became a huge problem for 3D scanners because now we get many more counts coming in because we don't have that focusing on slices. So what happens is that for some application in cardiac, and I don't know if you do rubidium here, I don't know if you do, but that is one key application where this parameter becomes absolutely critical, and I'll show you examples of this. If your scanner is saturating during this first input phase, when you do the dynamic blood flow scans, then your stress and rest, for example, can be like 50% different than it actually is, just because the scanner is saturating. And even at this kind of levels here, you know, of this 120 kilocounts per second, it actually can already saturate for rubidium scans. So that those new scanners probably you will avoid this issue, but this is the scanner just released a few months ago. So with 3D imaging, you have to always worry about the injected dose and so forth, especially with rubidium, because rubidium is a very short-lived tracer. So you can imagine you have a lot of counts. You give a high dose. It, of course, is a low dose to the patient because everything goes out very quickly. But nevertheless, for the scanner, there is a lot of counts, especially at the very beginning. So this, we will talk about time of flight. Are you familiar with time of flight? So that, and we will talk about it, but this parameter here will define how accurate this time of flight is. And that is to do with the electronics, how precise you can determine where this annihilation took place exactly, based on the difference between the timings, between the, you know, where the two different photons hit the crystal at two sides, and there's a little difference in timing. So depending how precise the scanner can detect this difference, that will define your time of flight resolution and time of flight localization. This is a little easier to understand. That is in centimeters. So here, the first kind of, when the time of flight was used a few years ago now, introduced the actual timing, like the resolution is like 5 to 8 centimeters. It will locate that photon, that annihilation spot within 5 to 8 centimeters. But those new scanners go down to like 3 centimeters. So you can imagine everything improves because now you know a little bit more about where those photons are coming from. And then you have a coincidence window, which is like how many, you know, what you accept within how many nanoseconds you accept something to be a coincidence event. Now, I will talk a lot about this. All those scanners now have something, the reconstruction is always based on some kind of resolution recovery. This has pretty much become like a standard option on a lot of these scanners. And that is what when I was saying that resolution effectively goes up to like 2 millimeter, it's because of this reconstruction option. So, and I show you some cardiovascular application, when you want a very small lesion size, actually it applies to oncology as well, you really want to use this option. It's probably one of the most important developments in PET and also in SPECT to use this resolution recovery. So on different systems, they have different name. On Siemens, it's called HD. On GE, it's called Sharp IR, and there's like different ones. But this is what, if you want to go to high resolution cardiovascular imaging, you really want to use this option. So this is like a big overview, and you have the table of what's available right now. And the green one is like the latest one. And I highlighted in red the kind of key important parameters here. So just going to these crystals, you know, so this is your conventional PET scanner. You have four, usually it's packed like this, that you have 4 photomultipliers, and the photomultipliers are just like in the gamma camera, old photomultipliers, there's just more of them. And you have a crystal here, and you have this crystal element. So this is what we talk about, this 3 millimeter or so is this element. They're not exactly cut, they're like kind of, you know, not fully cut usually, there's like a little groove. And you have here the, you know, the packs of four multipliers. Now there's some other design which kind of help it, and one of them Siemens started with this something called this Avalanche Photodiodes. So this was the first thing on PET-MR, and we'll show you the PET-MR. It's only used on the PET-MR. So it's not really silicon photomultiplier, but it's like photodiode. Photodiode is something which, you know, it's like used in many applications, like where you detect light, you know, maybe in your, you know, when you detect someone going through the door and so forth. So actually here, you have still the crystal, and actually in all these PET designs, you still have a scintillation crystal. Then in this, so in replacing these photomultipliers, you have this, in this case, is Avalanche Photodiodes. And in this case, this is more used right now, this, we call it analog silicon photomultiplier, because the silicon photomultiplier, it's, you know, it's like a digital device, but then it has this, you know, kind of still analog output at the end. And then it's then we call, there is some kind of board, which is usually called ASIC. You see that all the time. It's application-specific integrated circuit. But it's really just taking the output from this. So this silicon photomultiplier replaces this. So either Avalanche Photodiodes, APD, or the silicon photomultiplier, which is used most of the time, is the typical design right now. The Philips has something very special, which is the digital silicon photomultiplier, which is directly going in digital signals. So it's like you have this silicon photomultiplier, but then there are digital signals, and they directly go and digitize the, you know, the output like within exactly where the crystal is. So technically, maybe this is a superior design. However, the parameters are not any better right now, at least. So, but this is a quite different design. But essentially speaking, this will be the most common, this analog silicon photomultiplier. So you replace your, you know, your kind of a conventional tube with this circuit. And that circuit is simply detecting light and then converting light into some kind of electrical current. So when you probably learn about CZT cameras in SPECT, there's a new cameras like D-SPECT and G4530. It's very different, because those cameras, when you talk about this digital SPECT and this new crystal SPECT, actually there is no scintillation crystal, because there's no conversion to light. You directly detect radiation in the, you know, with the CZT detectors. Whereas here is the same as in the old camera, that the photons get converted to light in the scintillation crystal, and then you detect that light with, instead of photomultipliers, now you have some digital light detectors. So this is what digital PET is right now. People talk about like a fully digital where you don't have scintillation crystal, but this is like a long way away right now. So that's in a nutshell what's happening. This is this digital interface where, you know, you would directly, instead of this, as we've shown, you would direct, and this is what happens, you know, on an analog, where you have to figure out from multiple photomultipliers where you are, and on a digital system, you will just digitize exactly, you know, to that particular location of the crystal, and will tell you intensity in that crystal. So it's a little more advanced than having like this just silicon photomultiplier, but it's similar. So here is this saturation issue. So there's a nice paper in JNM kind of touching on all the technical issues of PET imaging. I recommend you read that article in JNM 2018 by Murthy. And what's happening here, so when you do dynamic scan, and especially with rubidium, what happens is that your activity is very high here. So we actually have like 40 millicurie or sometimes. Now we're trying to lower this dose because it's, but this activity very quickly over time becomes very small because rubidium half-life is very short. So, but unfortunately at the very beginning here, in the first 2 minutes, when you do dynamic imaging, you may actually end up with some saturation. So not here. So if you do perfusion imaging, gated imaging, doesn't matter. But when you actually want to do dynamic flow, it becomes an issue. For ammonia, you see, it's a less of an issue here. Because the ammonia activity is more or less the same all the time. It's not really changing. Its half-life is longer. It's not such a big issue unless you have a very high dose. So if you look at this, this is like over time how this peak count rate was increasing. So here you see different scanners are on the graph here, and I put, because this is an older paper, I added the new Biograph Vision. Is right here, you see, at 300. So it really jumped quite a bit, and I think that really solves this particular problem. So, but if you talk about rubidium imaging on this 3D scanners, I think this is something still of a big concern. And you want to look at this parameter, you perhaps want to lower your dose to have a lower dose, or perhaps have a little longer bolus and so forth, because we still have a problem with it. So what happens with the saturation? So here's a nice paper by Dr. Taut. It was in Nuclear Medicine Communication in 2012. So here is like the scanner, and here it shows you like where different detector blocks are being positioned, like in color coded. This is what you actually image. This is like a raw image from the scanner, the counts coming into these detector blocks from which you do the reconstruction, and then you see this kind of strange behavior, some strange kind of patterns in these detector blocks. Is where some saturation may be occurring. And this is, in this case, that maybe there's some activity, very high activity at the very beginning, could be in the arm, could be like during the injection, could be anything in the field of view of the scanner can saturate it. So what happens then if you do like a dynamic imaging? You have this input curves where you put a input ROI and you want to look at the blood curve and your initial blood input and the pattern. And this is what happens. So this is the example where you have a stress and rest blood input, and you see the difference here. So here is from that paper. You here have an example of the stress saturation, and here you have an example of rest saturation. So whenever you look at this dynamic quantification of rubidium on the scanners, you want to look at these curves and see are they any different on stress and rest. Because if they are, maybe it is an issue. Could be something else, but this could actually affect. You can imagine if you tell the computer that this is your input to the heart, it will falsify the results. It will not be a correct result after. So what happens if that happens? So this is from another paper from JNM, from Renault, from Ottawa group here in Canada. Actually, it's a very strong PET group in Canada. We refer to their papers all the time. They publish a lot of technical papers. So here you see you have the blood input and the myocardium, and with a low dose, you have a low dose and a high dose image. And you see whether the green is the high dose and the blue is a low dose. So what's happening, with the high dose, the peak becomes smaller. So why is the peak smaller? Because it gets saturated because of the high dose. So that will affect what will happen then. You see your mean blood flow in the heart gets higher. Why does it get higher? Because you can intuitively think about it, like the computer thinks less is coming to the heart through the blood, but then it actually gets more in the tissue. So somehow the flow must be very good, right? Because you're getting less in the blood, but then it gets more in the heart. So that is like falsely kind of increasing the flow, the perception when you do quantitation. So this is what will be your, kind of a result from this. So this new, so when you draw this, like when the vendors introduce this new scanners, they draw these curves, like to show how the system behaves as you increase the counts, what actually the system can record. So this is like this, they draw this neck equivalent count rate curves. And you can see here, this one of these curves is what happens is as you increase the activity at some point here, your system will just have saturate. So it will just show you, even if you increase activity, it'll be the same or even less. So here you see the new scanner, you see how much more you can extract of the count. So you can use lower dose and still the counts are increasing at like higher and higher activity. They're increasing still, only saturate only at some very high levels. So this is something important. Another thing, I don't know if you heard of this, is prompt gamma correction. So that's something when you do rubidium scans, and this is like in cardiac in US at least, and in Europe to some extent, rubidium is like the working kind of horse of the cardiac imaging. There's like maybe 200 sites in US which do rubidium. And what happens then when you started to do this 3D imaging, this wasn't so much an issue with the older PET, so this never came up when people were publishing these papers on older PET, but this new 3D PET, this became a big issue because like all the models, scatter correction, everything stopped working correctly. So what happens is that when rubidium decays, there's about 14% of this positron decays actually produced a single prompt gamma at 776 keV. So here it is. So actually it's not only annihilation, but there's another 776 keV photon. And that photon, it contaminates the data. So when we had these 2D scanners, it wasn't so important. But now when you have the 3D scanners, became a big issue. And that has to be corrected. So the vendors actually had to change the algorithms to correct for this. So this is something called prompt gamma correction. So when you do rubidium on those scanners, you have to make sure you have that option, and this option is turned on. Because if it isn't, there's some dramatic differences. Here, you have a without, this is with. So when we started in 2008, we started to do rubidium scan. We got a nice brand new scanner, and the vendor didn't know about this. And then we're getting these crazy scans for like 6 months or so. And then, what happens is that we found that this is a huge problem. We talked to the vendor, they retrofitted us, we recorrected all the data, and we could then do it correctly. But this was something which was not immediately recognized by the vendors when they introduced this 3D scanner. So you always, when you get a new toy, you want to be conservative, you want to check everything because things can be, different than before. And this actually has effect on the flow also. And there's another paper in 2016 here showing if you do the flow and you do this PGC or no PGC, you see the curves are different. And then you will have differences in flow, and it will be in obese patients, and LAD-LCX territories will have the biggest effect. One paper here, Journal Nuclear of Cardiology, which talks about it. So now let's talk about this PET resolution recovery. So this is, to me, is one of the most important aspects of imaging on those scanners. And this picture, this is from an older paper, shows you how this is done. In this one particular implementation, in the company factory, they put a scanner and they put a robot, which put like a point source, and that robot can move this point source in X, Y, and Z. So they will obtain many different images, like the whole map, what the point source looks like at different locations. And you can imagine that if the point source is somewhere here, close to the edge of the scanner, the point source will look like this. And when you're more in the middle, the point source looks but like this. So over a whole night or something, they collect many images of these point sources for different, a 3D map of the whole field of view of the scanner. And then they use this map to kind of reconvert when they get patient to reconvert, and they think, to kind of readjust this resolution based on those profiles. So this is like these maps are generated for each model of the scanner. So it's like, let's say you have a biograph, a specific map for the biograph, and some other one for another system. But basically, the whole principle is that you try to recover the resolution based on knowing how this is kind of happening in the controlled conditions, and then you put it in the reconstruction and try to like invert it. So this is now using all the scanners, and it really affects a lot the results, and it's usually in a good way. Here's an example from our older paper to show how, when you do this HD PET on that scanner, you see, and this is ungated, and we talk a lot about gating, so there's a little subtle, this effect here, but you can see already, the resolution is higher. It's just by using the different option in the reconstruction makes a difference even for this kind of ungated cardiac imaging. But it becomes really a big issue when you start looking at very small lesions. So in the next session after the break, I will talk about these small lesions and PET imaging with this coronary PET. And, oops, sorry. And so you see, when we use this resolution recovery, or we don't, the differences in the very small lesions are about 4 times higher SUV. So you can imagine if people report some papers and they tell you SUV is so much, well, you really have to know if it was using resolution recovery or not. Results can be dramatically different, to that extent that it's totally uninterpretable sometimes without it. So it becomes a really big issue. And you can see the contrast is this is a phantom study actually, but I'll show you images in the patient. So now time of flight. So there's another very important new development. I mean, actually it's not really new. It's been around from the beginning of PET times, but this is only now, last few years, when it actually is put in the clinician's hands. So you're familiar with this concept that when you don't do time of flight, you just have a line of response, and then you measure, from this line of response, you reconstruct. It's like filter back projection or iterative. You'll figure out eventually where this activity is. But the activity actually is happening here, but you are assuming it can be anywhere on that line. So you can imagine, and when you do it, there's a lot of noise because of this. So if you can help yourself and find out exactly that, okay, your activity actually happened, within this area, then if you tell the reconstruction algorithm, okay, don't, zero it below this values, it has to be somewhere from here, you can imagine that it will improve your noise and so forth properties. So it's the question then how wide is this? And then I was showing you that table before, and it was going from 8 centimeters to 3 centimeters of the new scanner. So there is a big difference in how well the scanners can tell, where this is actually occurring. And this is, one thing to remember is that these photons move with the speed of light. So it's pretty fast, right? 300,000 kilometers per second. So you can imagine that this, when within like this 3 centimeters movement of light is in the order of very, fractions of nanoseconds. So it's the electronics has to be capable, and the detectors have to be fast enough. That's why the digital detectors are much better here to be able to cope with this. So and also the examples, the first examples, how in the oncology scan, how much nicer and cleaner this image is, it's less noise and so forth. So this was a big. First, it was used in oncology quite a bit, but then people start to study it in cardiac imaging. So basically, the consensus is all the research papers were showing that time of flight really goes together with this resolution recovery. You really should not use separately, because here they show this, in this case is HD. So here is like the HD is this one, the time of flight is this one, but then when you actually combine them, this is your contrast in a sphere. This is with number of iterations. So your contrast will be always best if you use together the time of flight and resolution recovery. So that's been shown in many papers. And here, some examples from a study by Tomiyama, JNC 2014, showing you like a better, better definition of the lesions. It's like images are cleaner for cardiac. It also shows that it has an effect on flow. So this Dr. Armstrong from Manchester, he was showing here that actually the flow results will change quite a bit. So that's something important when you compare flow results with and without time of flight, is that they may change. So it's not necessarily exchangeable. So you want to, like if you process some data and you use time of flight now, then you want to maybe reprocess the data from before. And so there's a couple of papers also showing, recent papers showing that this is a more complicated physics paper, but the important thing here is that if that when you do different reconstructions, and they show that when you apply this that you apply this different number of reconstructions, and when you add that when you don't have time of flight, what happens is that the different reconstructions, depending on number of iterations, they give you different results. But when you add time of flight, then actually it becomes very similar. Everything becomes very similar. So this paper was showing you the concordance, depending on what kind of filter you use or how many reconstruction you use, it became more uniform when you actually use time of flight. So this is important. There was another paper showing this here in it's kind of an obscure journal, a little obscure journal, but you can find it online. So when you do the flow, you have this K1 and K2 parameters. And here they show how the K1 and K2 change with number of iterations. So you imagine you have different number of iterations, maybe you have different results. So what happens here, if you use time of flight, what happens is that immediately after 50 equivalent iterations, equivalent meaning you multiply the number of subsets with number of iterations. So usually it's like, say, 2 iterations, like 16 subsets or so, or 34, it will become like here somewhere. So what happens is with time of flight, it becomes, that K2 stabilizes is the same. Same here, with the, when it stabilizes earlier, so it becomes less important how many iterations you use if you have time of flight. So there's like at least 2 papers showing this. Now there's another type of reconstruction, but it's only available on a G system. It's a Bayesian likelihood reconstruction. So that one, it's more advanced, and we don't really know yet how it performs. So we tried it in our lab, and we couldn't get it to work for the sodium. There's one paper showing that depending how you use it. So this is not resolution recovery. It's like another option where they do model the some statistically the likelihood of correct reconstruction. And I would say it's still experimental. They have a parameters called beta, and depending what beta you use, you get different results. So here they compare, they will compare this is filter back projection OSEM, and then you have this different beta, and you see the images are quite different. So somewhere here is good, but this is really better than awesome. We really don't know. So I would say that reconstruction is there. The vendors offer it, but I would say that this is something still experimental. You can play with it, but I would not. I'd be careful using it for flow and so forth. So this was about the hardware. So this is like back into that table, which we spent a long time before, just to summarize. So you see what happens here. The new scanners, they have a very high count rate now. That avoids the saturation. They have a very good, crystal resolution. You get a higher resolution. All of them will use this resolution recovery, either the SHI-PyR or the high definition reconstruction. And they have a high sensitivity now, so you get more, like a higher, more counts, lower dose. Digital, a lot of them are, they have the silicon photomultipliers, so they don't use the analog photomultipliers. And your timing of the time of flight resolution gets shorter, so you can better tell, where exactly these photons are coming from. This is like in a nutshell what the hardware PET-CT is right now. So now I like to talk a little bit about the motion and what can happen, what happens in, because actually the motion, if you have motion, none of that really matters, because it can be a dominant effect. And actually, the better the scanner becomes, the higher the resolution, the better your definition, the motion becomes more and more dominant, because it's now, the amount of motion compared to the resolution becomes really huge. So there's different kinds of motion and different problems. So one of the key problems, still not fully resolved, is the misalignment between the attenuation maps and PET. And this is a motion between when you do an attenuation scan and then a PET scan. Because attenuation scan is a CT, and it takes only a few seconds, and then PET takes whatever, 10, 20 minutes. It's done at a little different time. So it's still a problem. So one solution is that instead of that, right now what we use is we use this CT, which is, we use the CT, which is just a helical CT, and it will be, let's say, in end expiration. So it may not match exactly where the PET is acquired because it's average respiration. So there may be some misalignment, not just because of patient motion, but because of some, like the difference in respiration. So here's an example of this. So one of the solutions is to use this kind of average cine CT. It will add a little radiation, but you can acquire on the systems. You can acquire on the systems kind of the CT, which is more resembling the PET respiratory position. And it actually it has not been used by anyone other than Dr. Gould in Texas. I don't know of any other lab using it, but potentially this is a good idea, and actually it can be done on the systems. But it's not an easy solution. It's not something you can run your scanner. You need to get your technical support, and you get your physicists, and they have to figure it out. It's not a plug and play on those systems. And how does it work? So you will, you acquire this. So this is there's different on a G can be done with cine CT, on the low pitch helical CT, on the Siemens and Philips, over respiratory data. So you acquire this multiple position. But actually, for cardiac, we would just do one position here, and we do the averaging just from this position here, and it actually can be implemented without respiratory gating. On some of the systems, actually, vendors ask you to use respiratory gating. I don't know if you have it. It's like an optical camera on a G. It could be some other system, but actually, this cine CT can be performed without this device, but it's just that the vendors may not allow that option. So this is something which potentially can be done, but requires a little bit of fiddling with the system. Because if you had to use this respiratory gating, it's complex. You have to add it. You have to put a box on the patient. It just adds to the complexity of the whole scanner of the scan. It's already quite complex with ECG, everything, but it actually can be done without it. But there are other solutions. So one of the solutions is the software solution, where you register the data, no matter how this was acquired, you can register the data after the acquisition. And actually, vendors offer that kind of software, which align the CT and PET automatically for cardiac imaging. So typically, I don't know how you do it here if you do PET, but typically technologies in our place would try to check if alignment is correct in all directions. Like we use this, if you look at this scan, they use this kind of view, and they will just correct and try to align it. So that is what is a clinical standard. So what we did is we did a study where we compared what happens if you don't do any alignment. You just ignore that issue. You just reconstruct as if there was no problem. Then the blue line here is our clinical standard. That's what the technologists would do. And then we actually use that automatic software which would align it. And then the software had two ways we used it. One, that actually someone was checking to see if alignment is needed. If they thought it was okay, we would not apply the software. And the other way would be you would just apply on every case without even looking at it. And you see, even if we do it either way, and then we took like a very experienced radiologist who looked at all the scans and checked how much alignment there was, and she spent like half an hour and 1 hour on each case, which is not clinically feasible. And then we showed that actually there was, if we didn't do any alignment, then 40%, 45 up to 50% on stress of these cases were misaligned according to the experienced radiologist. So this is a huge effect. And if the technologies align it, there still was 20% left, or 20% left of cases which were not correctly done, because the technologies doesn't have time to really sit for 1 hour and check this thing. They have to run stress, and they have to run rest scan, and so forth. So still they missed 20%. The software, if you use the software, there was much better alignment within, like, there's actually one missing here, but the auto was about 6-7% according to that experienced radiologist. And actually we had invasive angiography for all these cases, so we could verify how well we detect obstructive disease. And you can see that indeed, when you don't do any alignment, you don't detect it so well. When you do some alignment by technologies, it's better. But when you do this automatic software alignment, it improves even more. So that's something simple to use, and vendors actually offer this. So you should ask and see if you can get it, because this is actually can improve your results quite a bit. Here are some examples of this. So here's a case, and here what happens. This is kind of obvious case here, where you have misalignment. And then here is, after alignment, and here is a defect, and that defect may only show on stress, not on the rest, because of only stress may be misaligned. And then after alignment, you see that it's like so dramatic differences in cardiac imaging. There are some more subtle defects, but which become like very difficult to read. This is kind of easy, but there's quite a lot of those kind of cases. So now there's another issue, which is kind of maybe, when you do cardiac imaging, you can think about. People show that calcium is very, very important. So coronary calcium can be easily done on all these new hybrid PET-CT scanners. They're all very high resolution, multiple slice CTs, up to 128 slice CT. No problem doing calcium. We have shown that just adding calcium and this and perfusion deficit, we get quite a bit of statistically significant per vessel improvement in detection of obstructive coronary disease. So what happens, even if you have absolutely normal perfusion and you have some calcium, you actually will be some more likelihood of disease. Here you really can rule out if you don't have. But similarly, if you have no calcium but you have perfusion defect, you will have still that still improves your chances. So those are very complementary measures. So now the thinking is, can you use it somehow together, and more, or maybe you can actually use calcium for attenuation correction, and maybe use this software to automatically align calcium with the PET. So you can get just one CT scan, which is actually a calcium scan, and automatically align it. So there was so this is actually a group in Switzerland. They use it like that routinely. There's our friends in Switzerland. They use it every day. They align manually calcium scan, and they will use this for attenuation correction. So they will have calcium scan for all the patients. But the manual alignment, we know is difficult. So actually, Dr. Zaidi in Switzerland, he showed that you could, using that software I showed you, which we studied also, you can take a calcium scan for PET, align it, and then, so here is like the original, scan, and then original align, and you can use that calcium scan, automatically align, so, and then you can use it for attenuation correction, and your results will be equivalent, as they show here, to standard CT, AC attenuation correction scan. So with the use of this new software, I think you could think of using calcium scan, because it's not only will give you attenuation correction, but will give you that extra information about the patient. Another type of motion, and this is something Dr. Akinchoglu probably remembers, because we worked on the paper in SPECT a long time ago when she was in LA, but then we moved on to PET, and we kind of worked on this some more. But here is the first result of just cardiac motion PET, where you apply this. And you can see that, first of all, you use this resolution recovery. It helps a lot. And then but if you don't correct for motion, you still cannot really resolve the small defects. So the motion is a very important effect. So you want to use together resolution recovery and motion. But there is also not only cardiac motion, but there's respiratory motion when you do heart imaging. And when you start talking about very high resolution, then everything becomes very important. Here is an example of a normal patient breathing, low-dose sinus CT, and that's like the kind of scan I was talking about for this attenuation correction. And you can see the motion can be like 13 millimeter here, 7 millimeter here, 17 millimeter here. So you can imagine that respiratory motion compared to 3 millimeter resolution of the scanner can really also affect your results. So you have a cardiac motion, respiratory motion. And so one of the techniques used by the vendors, which if you want to do this high resolution, they can gate the respiratory signal, and then they will find that phase, like a quiet phase, where they claim you can get 35% of your counts in that phase. So without any software, you could maybe just extract those 35% of the counts, and you'd be like correcting for the motion. That's one option. It's called optimal gating method. And you can see here is an example of respiratory gating and how much a heart is actually moving during the scan. But here we actually collect all the counts, not just that one gate, but all the respiratory counts. So we really believe in collecting all the counts, not just like throwing out 70% of the counts. So what we do is we corrected this, we improved that gating motion frozen method to now actually apply it to both the respiratory and cardiac. And when you do this, so this is the kind of like when you gate it, you can gate it for respiratory, you gate it for cardiac, and also different kind of timings, but you can get like 32 gates. And then you'll get these images in end expiration and end inspiration. And then you get them in 8 cardiac gates. And then you can freeze the cardiac motion in each of these respiratory gates. And then you can freeze the respiratory motion. So so this is the kind of technique. And then we compare it also to that technique which vendors offer, which just kind of cutting out all these counts which are supposedly moving a lot. And so here we have a cardiac images in this study. This is published in 2015, where we have like a summed image. That's what we typically use right now. Then you have the gated. Then we motion frozen just for cardiac motion. Then we use this technique for respiratory gating, and then we use all correction of everything. And here is like how the contrast to noise ratio. So how much contrast versus noise. And you see that when you apply all of this, the blue, it becomes. The contrast to noise ratio has increased dramatically. This is kind of like more visually to show what happens, because you have that cardiac motion and respiratory motion, and we have those vectors, and we correct both. And you see here what happens is you have these images. One phase, this is like the 3% of the counts. Very noisy, but we can still recover a lot of motion from there. This will be the ungated image. That's what you use today typically for like anything. This is a cardiac motion frozen. This is like just correcting for that respiratory motion, but not cardiac. And this is correcting for everything. And you see how you can start getting these images, and this is a fluoropyridase agent. So this is like the really high resolution agent. And of course, the high definition reconstruction and so forth. So when you want to get to this very high resolution imaging, maybe looking at the endocardial perfusion and so forth, you really have to do all of those things. Is another example of this in black and white, and you see that you really see these images are becoming much clearer when you apply all the corrections. And here, actually, you appreciate it with the fusion because you see the the papillary muscles and everything when you fuse it with high resolution CTA. So that's the kind of state of the art what you can do right now. And vendors actually are now introducing these techniques. So we've been working in research with this, but now you can get this. This is CardioFreeze from Siemens. That option is available, and they actually combine respiratory and cardiac motion, and you can apply. This is a kind of a package you can get on the system, and these are their results showing their improvement using this kind of software. And then the GE has something called QFreeze on the system, also available, and they mostly used it for like oncology imaging for the small lesions and so forth, but it will equally apply to cardiac imaging as well. And they show here, what happens is like the same concept, as the lesion moves, as you move all the counts to here, and they show in their white, they didn't publish it, but there's like a white paper describing it. So there's like a lot of different efforts to make that happen, especially now with these new scanners. And here's a reference. There's one reference published, actually peer-reviewed, on this method. So I will talk after the break. I will talk more about this different application of this motion correction and resolution recovery for coronary imaging. But here's just one example. And also notice that if you don't use high resolution recovery and time of flight, even if you do motion correction, is not the same if you use that resolution recovery, time of flight correction, and motion correction. Then you really start getting these images exactly, how you want it. So it's like a combination of all these new developments you really have to put together to get nice images. So now we move to PET-MR, and I know you have a PET-MR here. So a little bit about the technology of PET-MR. So there's different configuration. This is people were studying this Philips system where you had like separate, MR and PET. But now there's two vendors offer this kind of a combine, and I think we will talk more. I think we're more interested in this aspect now, where we have the PET and the PET scanner and the the body MR coil. Everything is put together because hopefully people believe that that is one way to solve all these misalignment motion problems and so forth. So that's one promise of PET-MR, that they can solve it, because now, unlike the PET-CT, you have it not separate but together, and maybe can acquire at the same time. There's a nice review of the PET-MR here from Dr. van der Berge. So here's a table of these two simultaneous PET-MR systems. And notice one thing, that so that system, the Siemens system, was using these Avalanche Photodiodes I was showing you. It was like another version of the silicon photomultipliers. And it turns out that Avalanche Photodiodes are not very good for time of flight. So because of that, actually, the Siemens system doesn't have time of flight. So this is actually a big disadvantage for us. But then they, of course, have a very nice PET-CT system where that is available. But keep in mind that this was introduced in 2011. This new system was introduced in 2016. So everything has changed. So you're really comparing, different time eras here. But so the G Signa is using the silicon photomultipliers. This is using the APD, and similar crystals, similar resolution. If you really look at the specs here, so this is the biggest difference, is there's lack of time of flight here. Everything else is similar. Sensitivity is a little higher here. And this is because we cannot really do the time of flight with this APD. So these are you had this table with PET-CT, here's your PET-MR table, so when you have all together there you can kind of compare. But generally speaking, the latest PET-CT systems have better PET than what's available on any of those PET scanners. So you don't get the latest, greatest PET necessarily here. But applications can be interesting here. You can use it for, some applications where in cardiac where you need soft tissue contrast, because that's really what MR gives you, is the soft tissue contrast. So we studied this aortic valve imaging where we look at the valve and then we look at the sodium. We'll talk about it a little more later. And then this is paper from our collaborators from Edinburgh. They use it for cardiac sarcoidosis, and they have a similar PET-MR as we have. So those are the kind of designs. This is as you see, these designs are very similar from Siemens and GE. It's kind of sandwich, that you have the RF body coil, then you have a gradient coil, and so here is and here you have a PET detector put in between. So this is, everything is done together. Same here on that system is a very similar design here. So it's just a different rendering of it. So one thing, and in this review, this is kind of covered quite a bit, that the PET has effect on MR and MR has effect on PET, so you always have to be a little careful about it, but that's something it's a vendor's job. But the MR, can change the path of electrons, can, heat, vibrates, they can interfere with electronics. So this is why this system really cannot use this analog PM tubes. So they use this APDs, or the silicon photomultipliers. This is the main reason. But now it seems like those silicon photomultipliers are better even for PET-CT. But that's why they started to develop it here. And they have to redesign all the electronics to cope with all these temperature changes and everything. So obviously the cost is higher of everything. The complexity is higher. Then PET can have an effect on MR. because you'll have like you can introduce some non-uniformities of the magnetic fields and so forth. So those are the kind of things which make the whole system more expensive than if you get PET and MR separately. So that's why the systems are so expensive. And our place is still, our research VPs are still talking about how expensive that system is. They bought it a few years ago. They still talk about it. So one thing about this PET-MR is that the motion, there was a big promise that you can do this dual motion compensation and that you can use MR to track motion and kind of apply it to PET. So it can be done, and there's like several papers showing this application. And here's an example using this kind of dual, just like we shown in PET CT. Here this is in JNM paper. They show how they can apply this, and they can do find this this is kind of like a cut through the ventricular wall, like here with that line, and you see that without correction. You get a lot, that your full width at half maximum, the wall becomes thinner and becomes, higher activity in the wall and so forth. So obviously it's going in the right direction. So this can be done. And there's another paper here by Grimm. So there's like quite a few of these papers showing similar things, that motion correction can be done with the use of PET. But I would like to say one thing, that is, even though this PET MR everything is done at the same time, it really isn't, because the PET can last for 10-15 minutes. MR is not going to be done for 10-15 minutes for the motion, because it's a waste of MR time. During that 15 minutes, you could maybe do delayed enhancement. There's so many things you could do with PET MR, not just track motion. It would be a very expensive motion tracking device. So still, if you do PET MR, you can track motion at some time, but then, does it mean the patient stays exactly the same all the time? We don't know. So it's still, even though you can do it, it's not really problem solved. So we actually think that using this PET-based technique, even in PET MR, can be beneficial, because you can use MR for something else more important than motion, and actually use PET and these techniques, self-gating, like trying to find motion from PET images alone, and then maybe just validate with PET-MR. So another issue is that with the PET-MR, you have to do attenuation correction. And it is different than PET-CT. So what people do is they will segment the MR, and they will try to assign some activities. And typical method is this, using Dixon sequence and then segmenting it to 2 tissues and so forth. And the one paper from Lau, this is a very nice paper, got some award recently in Journal of Nuclear Cardiology, describes these techniques and how the results are not that different in their paper. Although, if you look at these Bannerman plots, some SUVs are different. So it's not the same. But they show, that it is corresponding. However, there's another paper by Dr. Lassen in Journal of Nuclear Cardiology recently published. Actually, Dr. Lassen works with us now at Cedars-Sinai, where they show that when you use this, if you use this attenuation correction on the PET MR, there is a number of patients are affected by truncation. Is a big issue on this. So truncation of this MR maps affects many patients. And then, there's some other types of artifacts here, respiratory misalignment still occurring, when you correct on this PET-MR system. So it's really not a solved problem, according to this paper. You still have all these artifacts, just like you had in PET-CT, you have it here. So it's something to really remember, that when you do PET-MR scan, you really have to look at these maps, you look at your artifacts, because it's not going to go away like all those issues. So it's not a magic device which will solve all these problems. So on the average, when you look at this, we'll say that PET-MR is more expensive. Attenuation correction is a questionable issue. It's still, people work on this. I think it can be done. One of the techniques developed now, I just saw a new papers coming out now. We work with machine learning. I was giving a talk yesterday. I'm going to give one talk tomorrow for different application. Actually, people try to use this deep learning to learn the CT maps from MR and use this machine learning to really learn, what should attenuation be. And that seemed to work better than all these other techniques so far. So it's still many things going on. Motion correction, it works maybe, but as we've seen that really your PET MR is not done during all this time. It's going to be just a fraction of the time. So it maybe is better, but on the PET CT maybe you can also do motion correction, and maybe it's not a big difference. So you still have this problem of attenuation correction misregistration. It's a big problem. It will be a problem on PET MR and PET CT. You will get a much higher soft tissue contrast on PET MR, so if that is a key importance, that becomes very important here. Radiation dose, it is smaller, but you have to keep in mind that we're talking about like an extra 0.5 millisievert or so for that CT scan. And now we're talking maybe using calcium scan as attenuation correction. So actually that radiation is not spent for nothing. Maybe it will be something important for you to also learn. So that is a little question over here. And then something we will talk about after the break is that the CT angiography really is hard, or angiography of the coronary vessel is hard to do on a PET MR. It's possible. There is some research in this area, but it is possible. It is a little difficult. So if you want to do coronary PET, probably better to do with PET CT. So in summary, we'll say that big development is the digital detectors in PET CT, because it was driven by the PET MR, but now actually on PET CT people use this, and it shows it has higher resolution, higher the count rates. We have this corrections for the resolution, as I've shown, very important, and then correction with time of flight. They usually go together. That will give you improved image resolution, and overall you get much higher count rates also, which will be important for rubidium. Because of all these new developments, the image quality is so high, the motion correction and motion becomes a dominant effect, and you can actually do dual-gated techniques even on PET CT, not on PET MR. This will be a key factor in your quality of images. It's not going to be this reconstruction is going to be this motion probably. And PET MR can be doing simultaneous acquisitions. It is expensive, but it has better soft tissue contrast. Potentially, you can get MR-based motion correction, but it still works in progress. So with that, I'd like to finish, and then maybe we can discuss for the next 15 minutes or so different questions and different problems you may have here. Thank you. Yeah.